Hello everyone, I'm Dr. Anupama Chowdhry Devgan, your physiology faculty. This is physiology in small doses, making it more palatable, I guess. This is an FMG quiz. It's a quiz on the FMG pattern. It's a mixed bag of 10 questions. This is the fourth quiz in the series. And of course, this is in the run-up to the FMG exam in 2025. So let's have a look at the first question. When ORS is given to a patient, glucose is absorbed by which of the following transport mechanisms? Now, when I look at the enteroside, on the luminal side, the absorption of glucose will be via a sodium-glucose co-transport. And this is also known as SGLT, sodium-glucose linked transport. This is an example of secondary active co-transport. The protein which is responsible for absorption of sodium and glucose here in the small intestine is SGLT1. The glucose will leave the basal side of the cell via a GLUT. GLUT is a glucose transporter. That is an example of facilitated diffusion. And the GLUT which is responsible is GLUT2. So it's a secondary active co-transport and facilitated diffusion. Of course, both are given in the options. Then why did I choose secondary active co-transport? Because please remember, the mechanism for absorption of glucose from the lumen into the cell is secondary active co-transport. It's only once it reaches the cell and it has to be transported into the blood that GLUT is used. So my best answer, secondary active co-transport. Which of the following maintains the asymmetric concentration of ions across the cell membrane? Now there's a little catch here. The catch says what maintains it? What is actually responsible for this asymmetric concentration of ions? What is this asymmetric concentration of ions? You've got a high sodium outside with a low potassium and a high potassium inside with a low sodium. So what is creating this is a differential permeability of the cell membrane, the Donan effect, but what is maintaining it is the sodium-potassium ATPase pump. Now, the sodium-potassium ATPase pump pumps out 3 sodium and brings in 2 potassium. We know that sodium is in a higher concentration outside, lower concentration inside. So whenever there is a leak of sodium, it's not a free movement of sodium because cell membrane at rest is almost impermeable to sodium. But small amounts of sodium can leak from outside to inside. And similarly, potassium can go from inside to out to maintain the ionic balance or to maintain this asymmetric concentration. The sodium-potassium ATPase pump is important. Sodium-potassium ATPase pump will push the sodium outside and bring the potassium inside. Right? Please remember, for sodium-potassium pump, Nokia, cell phones by Nokia were very popular. And remember the model 3-2-1. What does this mean? The sodium-potassium ATPase pump pumps out 3 sodium outside. Sodium outside 3 brings in 2 potassium inside. Potassium inside 2 for each ATP hydrolyzed. Which of the following molecular motors is primarily responsible for transporting vesicles in an anterograde direction? Now, what is anterograde direction? Vesicles are produced in the cell body and they will move away from the cell body till the nerve terminal. That is known as an anterograde transport. Now, this transport through the axon, which is also known as axoplasmic transport, it requires microtubules. These microtubules will serve as tracks. Moving on the tracks are the molecular motors. And for this type of transport, you also need ATP and calcium. So the microtubules serve as tracks. Moving on the tracks are these molecular motors, and they require ATP and calcium. These molecular motors are in fact ATPases. They have the ATPase enzyme. This is what is known as axoplasmic transport. Away from the cell body is anterograde, towards the cell body becomes retrograde. Now, the molecular motor which is used in an anterograde transport is kinesin. Dynein is used for retrograde, towards the cell body. Like, for instance, viruses. Viruses will move towards the cell body, neurotropic viruses like rabies virus. So that the transport of rabies virus in a retrograde fashion uses dynein. Myosin 2 is a contractile protein. It is not a molecular motor. The molecular motor is myosin 5, which is also used in anterograde transport. Inhibin is responsible for which of the following? Now, GnRH from the hypothalamus acts on the anterior pituitary. It causes a secretion of FSH and LH from the anterior pituitary. FSH acts on Sertoli cells. Receptors for FSH are on Sertoli cells. And the Sertoli cells will now secrete inhibin, and this inhibin has a negative feedback effect on the secretion of FSH. So it causes an inhibition of the FSH secretion. LH receptors are present on the Leydig cells. Remember, L for LH, L for Leydig, and Leydig cells secrete testosterone. Testosterone has a negative feedback effect on the secretion of LH as well as GnRH. Testosterone will also increase the activity of the Sertoli cells. Right? So inhibin causes decrease in the secretion of FSH. Which of the following is not an action or effect of parathormone? Now, parathormone is secreted by the parathyroid glands. What causes increase in the secretion of parathormone is when there is a decrease in the plasma calcium levels, or if there is an increase in the plasma phosphate levels. These will stimulate the secretion of parathormone. Now, parathormone receptors are present on the osteoblasts. The second messenger for parathormone activity is cyclic AMP. Now, what are the actions? Even though the receptors are present on osteoblasts, but parathormone causes a secondary increase in osteoclastic activity. By acting on the osteoblasts, it increases the secretion of something called rank ligand. Rank ligand increases what is known as monocyte colony stimulating factor, which acts on osteoclastic precursor cells and converts them into mature osteoclasts. So it increases osteoclastic activity. So it increases bone resorption, yes. Does it increase the calcium reabsorption in the kidney? Yes. Parathormone acts on the PCT, on the DCT. On the DCT, it increases the calcium reabsorption. Does it increase the phosphate reabsorption in the kidney? That is incorrect. It in fact decreases phosphate reabsorption in the PCT. It inhibits, parathormone will inhibit the sodium inorganic phosphorus co-transport. Inorganic phosphorus and phosphate are the same things, right? So it inhibits the sodium inorganic phosphorus co-transport. This is called a phosphaturic action of parathormone. Parathormone reduces sodium inorganic phosphorus co-transport. In other words, it decreases the reabsorption of phosphate. So it increases the urinary excretion of phosphate. That is called a phosphaturic action of parathormone. Does it increase calcitriol synthesis? Yes. Parathormone increases the activity of 1-alpha hydroxylase enzyme, which is present in the kidney, and this causes increased production of 1,25-dihydroxycholecalciferol, which is also the active form of vitamin D. Which of the following statements is true about tone of the lower esophageal sphincter? Now, lower esophageal sphincter tone. A decrease in substance P increases tone? No. Substance P is a smooth muscle, produces smooth muscle contraction. So substance P would have, increase in substance P would have increased LES tone, but so this is not correct. Increased ACH increases LES tone, that is true, because acetylcholine will also cause a smooth muscle contraction. Nitric oxide is a smooth muscle relaxant. So this is false. Meissner's plexus, it is a myenteric plexus which is involved in motility and smooth muscle contraction. So the answer to this becomes B. A person hiking in Leh has increased rate and depth of respiration. Which of the following is the most probable reason for high altitude hypoxia? The moment we go into high altitude, there is a decrease in the atmospheric pressure. And that causes a decrease in the PO2 in high altitude. PCO2 is not high in high altitude. Difficulty in expanding the chest in cold weather is not the reason. It is in fact a low barometric pressure in high altitude. So my answer is low partial pressure of oxygen in the atmosphere in high altitude. Why is there a low partial pressure? Because the atmospheric pressure is low. See, how do we calculate the partial pressure of oxygen? This is the fractional concentration of oxygen into the atmospheric pressure. What is the fractional concentration of oxygen? How much is the percentage of oxygen into in the atmosphere? 21%. So 21 upon 100 into the atmospheric pressure will give us the partial pressure of oxygen. Which of the following changes in JVP are seen in cardiac tamponade? You know, in JVP, you have A wave due to atrial contraction, C wave due to bulging of the closed tricuspid valve in the right atrium during isovolumetric contraction phase. Then there is the X descent, which is because the closed tricuspid valve is pulled downwards during the phase of ejection. This increases the right atrium volume and therefore reduces the pressure. Then you have a V wave, which is due to venous filling of the right atrium, passive filling of the right atrium, just before opening of the tricuspid valve. And when the tricuspid valve opens, blood will flow from the right atrium into the right ventricle, giving us the Y descent. Now let's try and see what happens in cardiac tamponade. Let's look at Cannon A wave. What is Cannon A wave? Cannon A wave is a very large A wave. A wave is due to atrial contraction. See, normally when the right atrium contracts, the tricuspid valve is open. This atrial contraction is responsible for the last part of the ventricular filling. But supposing when the atrium contracts and the tricuspid valve is closed, so the entire force of the right atrium is reflected in the JVP and you get a Cannon A wave. This occurs in atrioventricular disassociation. That means the right atrium is contracting against a closed tricuspid valve. This happens in what is known as a junctional. A prominent A wave. Prominent A wave, that means the atrium is exerting more force to push the blood through the tricuspid valve. This will be seen in tricuspid stenosis. It will be seen in the reduced right ventricular compliance. Now, in cardiac tamponade, what is going to happen? Now, in cardiac tamponade, the Y descent. What is Y descent due to? Flow of blood from the right atrium into the right ventricle produces a negative wave, which is known as the Y descent. Now, because there is a cardiac tamponade, it does not allow a proper filling of the right atrium. So what happens is the Y descent is blunted or absent. Let's look at something called the Beck's triad. In Beck's triad in cardiac tamponade, this is seen in cardiac tamponade, there is hypotension, there is soft or absent heart sounds. GVP is distended with a prominent X descent. There is the closed tricuspid valve is pulled downwards during ejection phase. It is pulled down to a larger extent, large increase in the right atrial volume and a decrease in pressure, seen as a very prominent X descent, and an absent or a blunted Y descent. Why blunted? Because the filling is going to be restricted because there is a cardiac tamponade. There is also a pulsus paradoxus. Yes, what is pulsus paradoxus? Normally, there is a fall in the systolic pressure during inspiration, but this fall should be less than 10 millimeters of mercury. If the fall in systolic pressure is more than 10 during inspiration, we call that pulsus paradoxus. So pulsus paradoxus, along with a prominent X descent and an absent Y descent, will be seen in cardiac tamponade. But the Beck's triad actually is hypotension, soft or absent heart sounds, and a prominent X descent and an absent or a blunted Y descent. Arterial blood gas analysis is performed in a patient in the ICU. His pH is 7.28, so pH is definitely low. Normal pH has to be between 7.35 to 7.45, 7.38 to 7.43. So this is definitely a low pH, that means acidosis. Bicarbonate is 28. Normal is about 24 to 25 milliequivalents per liter. PCO2 is 60. Normal PCO2, arterial PCO2 is 40. So this is definitely elevated. This is suggestive of which of the following? Now please remember Rome. What is Rome? Respiratory opposite, metabolic equal. What do I mean by that? Whenever there is a respiratory cause of acidosis or alkalosis, look at the pH and look at the PCO2 levels. If the pH is low and PCO2 level is high, this will be a respiratory acidosis. If pH level is high and PCO2 is low, this will be a respiratory alkalosis. So opposite. It's also called the seesaw effect. Low pH, high PCO2, respiratory acidosis. High pH, low PCO2, respiratory alkalosis. Respiratory opposite. For metabolic, we will look at the pH and the bicarbonate levels. If the pH is low and bicarbonate is low, this is a metabolic acidosis. Equal. They're both moving in the same direction. If pH is high and bicarbonate is high, we call it a metabolic alkalosis. So in this case, pH is low and PCO2 is high, so this is going to be a respiratory acidosis. So please remember Rome. Respiratory opposite, metabolic equal. Potassium is maximally absorbed in which of the following segments of the nephron? Now please remember whether it is sodium, potassium, calcium, chloride, all of these will be maximum absorption. Bicarbonate, maximum absorption will be in the PCT. 60% of these electrolytes will be absorbed in the PCT. There's only one electrolyte, one ion, which has a maximum absorption in the thick ascending limb, and that is magnesium. So please remember whether it's sodium, potassium, calcium, chloride, bicarbonate, maximum absorption will be PCT. Only for magnesium, the answer will be thick ascending limb. So these were the questions in today's FMGE quiz. See you soon.